Howdy and welcome to the 2021 Multiple Sclerosis Updates, a focus on new and emerging therapies, best practices in clinical management, and key considerations during the COVID-19 era. My name is Aaron Boster. I'm the founder and president of the Boster Center for Multiple Sclerosis in Columbus, Ohio. I'm delighted to be joined today by Patricia Coyle. Dr. Coyle is a professor and vice chair of clinical affairs and the director of the MS Comprehensive Care Center, Department of Neurology, Stony Brook University in Stony Brook, New York. On the screen now, you will see both Dr. Coyle and my disclosures. Today's learning objectives include recognizing the importance of early diagnosis and early treatment in reducing disability progression amongst people impacted by multiple sclerosis. Personalized treatment selection when starting, switching, or stopping a pharmacologic treatment based on its efficacy, safety, and importantly, patient preference. Evaluating the latest data on efficacy, safety, dosing administration of currently approved disease-modifying therapies to develop the optimal individualized treatment strategies for patients with MS. Evaluate potential benefits of emerging therapies in delaying disability, slowing disease progression, and improving long-term outcomes in multiple sclerosis. And lastly, to identify up-to-date recommendations for patients with MS during COVID-19 era, including registries and treatment considerations. What you see on the screen now is the topographical model of multiple sclerosis developed by my friend, Dr. Stephen Krieger at Mount Sinai, also in New York. And Dr. Krieger has introduced a new way of thinking and conceptually thinking about multiple sclerosis, which I find to be really compelling. This is actually a model that I use in almost every clinic discussion, and I'm excited to briefly share it with you now. What you see on the screen is a cross-section of a swimming pool. And sometimes people actually refer to this model as the leaking pool model of multiple sclerosis. The surface of the water is the clinical threshold. So in this model, anything above the surface, the human being with MS, they're aware. They have a symptom that they know about, like an optic neuritis. Everything below the water, the human being is not aware of, but you can see it as a spot on the MRI. Now, the amount of water in the pool represents the functional reserve or neurological reserve. And as you notice, there's more water at the deep end. There's a larger functional reserve at the deep end than at the shallow end. The functional reserve is really a measurement of your nervous system's ability to withstand an insult, not you're ugly, an insult like you have a fever or an infection. And over time, that can change. We'll talk about that in a second. Now, the floor of the swimming pool represents the nervous system. And in that pink color, the shallowest part of the pool, this represents the spinal cord and the optic nerves. These are areas of the nervous system which we neurologists call eloquent. They don't have a lot of wiggle room. Damage to the optic nerve or spinal cord generally doesn't go unnoticed. Hence the reason there's a very small amount of water in the pool there. If you move from left to right, in the middle, in the yellow section, this represents the brainstem and the cerebellum, the infratentorium, which has a little bit more functional reserve than the spinal cord and optic nerves, but still not very much. And on the far right, in the deep end of the pool, here we see the lobes, the cerebral hemispheres, where there's the most functional reserve. Now, clinical attacks are demonstrated in this model by a stalagmite that's pushing up from the surface of the pool up above the water level, and that's a clinical attack. A new asymptomatic spot on an MRI would be a stalagmite that does not crest the surface of the water. And in considering this model as the leaking pool model of MS, over years, the level of water drains. And this model, interestingly, can describe almost any permutation of MS across the lifespan of the individual patient. It's an excellent way of understanding inflammation, activity, and also concepts of progression. This lecture will also address several key unmet needs in the management of MS, including trying to lay clarity on the positioning of early, highly effective treatment. Secondly, looking at biomarkers to predict progression risk and monitoring disease activity. And lastly, and rather timely, guidance on the management of MS patients during the COVID-19 pandemic. Let's now turn our attention to diagnosis and risk assessment. Here you see commonly reported symptoms that people impacted by MS may experience. This was actually a survey of over 5,000 people with MS. And I would share from my clinical experience that I think this is spot on. The most common symptom in MS, and in fact, the number one reason people leave the workforce, is pathologic and profound fatigue. As you look down this list, numbness, cog fog, spasticity and weakness, heat sensitivity, bladder problems, it's a rather extensive list of symptoms. And I would like to point out that many of them are invisible to the outside viewer, but it doesn't make them less real. We now turn our attention to the formal diagnosis of multiple sclerosis. We use a revised McDonald criteria. Now, this criteria is a work in evolution and was most recently updated in 2017. In essence, it allows us to identify someone who has had the first event, a so-called clinically isolated syndrome, that might go on to become MS. And by using your examination and features on the MRI, and now features in the spinal fluid, we can actually diagnose them prior to their second attack. This is a very sensitive and specific criteria. It's outstanding, and it's used in clinical practice, both in clinical trials and in our clinics day to day. There's also a revised McDonald criteria for progression for primary progressive multiple sclerosis. And this is comprised of both a year of progression plus certain features that are seen again on the MRI or on the spinal fluid. With that background, allow me to introduce Natasha. Natasha is a 24-year-old Caucasian woman who was recently diagnosed with a relapsing form of multiple sclerosis. Her initial presentation was multifactorial with profound fatigue and optic neuritis, and in addition, numbness of her hands and feet. Fortunately, she had a complete recovery following steroids. On examination, it's not normal. She has trouble discerning proprioception. She has a bit of a sensory ataxia, and her gait is a little bit off. MRIs revealed 4 T2 bright lesions. Fortunately, none were enhancing. An MRI of her cervical and thoracic spine reveal no lesions. Laboratories are unrevealing, and her JC virus antibody status is negative. When considering Natasha, we want to consider what else might we bring to the table? What else might we need in further testing? And if I could ask Dr. Coyle to weigh in, could you share with me, please, your thoughts on the utility of spinal fluid in helping confirm a diagnosis?
Thank you, Aaron. I think spinal fluid is key. At Stony Brook, we basically tap everybody. We do not have a diagnostic biomarker for MS. It's critically important to make an accurate diagnosis as early, as quickly as possible, and we know there is a misdiagnosis rate. CSF offers you a domain that's really independent of the MRI scan. The expectation is that the majority of individuals will be positive for CSF-specific oligoclonal bands, and the 2017 revised criteria really emphasized its CSF oligoclonal bands over IgG index that are key. So I would tap someone to look for oligoclonal bands and to look for red flags like a very high white blood cell count or protein that would point against MS. I also practice in a Lyme endemic area. We would routinely check for Lyme disease, reactivated herpes, screen for sarcoidosis, perform a cytology. So yes, I think it's a very important test, Aaron.
Now, when considering that I would submit about 90% of people impacted by MS will have positive spinal fluid, you're going to catch the vast majority. What about the people that don't have red flags on their CSF, but they don't have positive bands? How does that, do you just put that aside and use the clinical and radiographic data then?
So the spinal fluid result would not be the be all and the end all. I would not say you can't have MS because you're lacking oligoclonal bands. We know the data that says over time, the positivity rate increases. However, I would always have in the back of my mind a question about that individual. So I think that that's very fair. I'm going to act on the bulk of the data, but I've just found spinal fluid very, very helpful.
Absolutely. What do you think about electrophysiologic tests, evoked potentials? Visual evoked potentials or somatosensory evoked potentials are certainly not part of the diagnostic criteria. I personally find them to be a little bit less useful in a modern diagnosis. How do you interpret evoked potentials testing and part of the workup at Stony Brook?
Right. So rather than visual evoked potentials to interrogate the optic nerve, we are doing optical coherence tomography,
Yep,
OCT,
absolutely.
on every newly diagnosed patient. You look at the retinal nerve fiber layer. Is it thinned, indicating subclinical damage? It can actually go down to the ganglion interplexiform pure neuron layer. Remember, that's part of the CNS that has no myelin. It's
Yep.
pure axons and neurons. We are doing that routinely. To me, that's probably more valuable than the electrophysiologic um, test of visual evoked potentials. And I would certainly, among all the evoked potentials, I think the visual is the most helpful. I do know there's literature, if you were to speak to some very excellent neurologists on multifocal evoked potential,
Yep.
they believe they can be extremely helpful. So I'm not knocking it, but I'm just saying we would do OCT.
I share your opinion. I really view OCT as kind of like the poor man's brain volume measurement. It takes seconds to do. It's non-invasive, and I do think that when you see the patterns of temporal, for example, thinning, it really helps. It's not part of the diagnostic criteria, but I think it leads credence to the diagnosis. Evaluating risk of progression in considering Natasha, we have to contemplate prognosis. And I want to spend a few minutes and kind of talk through this with you, Dr. Coyle, if we may. How exactly might we characterize Natasha's prognosis? There's several features I think that are favorable. And as we talk through it, I want to kind of consider what those are. So I'll start off, being a woman prognostically is a bit better than being a man with MS. And diagnosis pre-age of 40 is also considered to be a good prognostic factor, as is Caucasian ethnicity. And so I would view those things as kind of in a good light. The absence of spinal cord involvement is a good prognostic factor, and a low burden of disease on her MRI and the absence of enhancing lesions. All of these are positive. Even the fact that she fully recovered is positive. Dr. Coyle, as you look through this case, are there aspects that catch your attention that might predispose her to be a little bit more aggressive, or what are your thoughts there?
Well, it sounded like on the neurological exam, she showed disturbances that might be a little bit disturbing. But then it sounds like they really cleared up completely, as I understand it, since it's noted that she, quote, completely recovered from her MS attack. Certainly, Natasha would not fit into a highly active, aggressive MS, or somebody where you're checking off the boxes with 10 plus bad prognostic indicators.
Correct. And if we change the case slightly, we could sort of shift our opinions a bit. If this patient was African American, for example, if they were a gentleman of 45 years of age, if they had not fully recovered, I definitely think these kind of things are what you and I are looking for in our clinics as we try to conceptually understand the prognosis. Let's spend a little bit more and talk about predictors of poor prognosis. This is a classic paper in our field looking at demographic features. As I mentioned earlier, being a gentleman, being over the age of 40 at onset of symptoms, and being of essentially non-Caucasian ethnicity are all poor prognostic factors. Physiologically, as mentioned, the presence of oligoclonal bands is a bad prognostic factor. We also look at the MRI, and multiple enhancing lesions at the time of diagnosis is a bad thing to see. Lastly, we can consider early disease characteristics, as Dr. Coyle and I just talked about. When you have motor involvement or coordination or sphincter involvement, these are bad prognostic places to have clinical involvement. Same thing goes for the infratentorium, the brainstem. Patients that do not fully recover from their initial attack, or patients that have a very short frequency between the first and the second attack, these are other factors which are poor prognostically. Rapid disability in a few years, or progressive presentation from onset, and cognitive impairment are also things that we may look for clinically when trying to identify poor prognostic factors.
What are the goals of treatment? Well, this may be aspirational, but I'm really telling patients in the modern era with MS that I expect they can live a normal life, that the MS is not going to prohibit them from fulfilling their life goals. And I really believe that we are seeing this change in our lifetime, changing the trajectory of MS to be an eminently controllable disease. Of course, that impacts in a very positive way on improving quality of life. None of our disease-modifying therapies, DMTs, are cures, but we want to control disease damage, of course, and we see patients who seem to be virtually completely controlled. So we want to reduce the risk of clinical attacks. It's very important to educate about that. We don't want disability worsening on the neurological exam. We want minimum new MRI lesions to be forming, really to minimize the CNS damage. And of course, to manage in an optimal way for improved quality of life symptoms, to get very effective treatments for relapses to help the patient recover quickly. Now, in turning back to Natasha, we have an initial visit that's really focused on disease-modifying therapies. And this comes from the American Academy of Neurology, their 2018 practice guidelines, where the DMT discussion was recognized as so important that it should be a separate discussion in and of itself. You want an educated patient. This is shared decision-making. You want them to understand the natural history of MS, that this is a disease that involves accumulating permanent damage to our most precious body organ, the central nervous system. There is no such thing as remission. I don't use the term relapsing remitting because this disease does not go into remission. People have a false sense that if they're not having obvious issues, the disease is quiescent. Not true. There's ongoing damage. You want to intervene to minimize that as early as possible. You want to talk about the life goals of the individual and not have MS interfere with that. There may be aspirational, what is our treat to target? There's no evidence of disease activity or NEDA that combines no clinical attacks, confirmed worsening, or macroscopic MRI lesions. In this DMT discussion, I like to broadly discuss the DMT options and pros and cons for each of them. And of course, we would evaluate when we really want to strongly encourage a high efficacy disease modifying therapy. When is that necessary? Now, this is the MS severity score, but it's giving a very important concept. So we're looking at the EDSS, Kurtzky Expanded Disability Status Scale from 0 to 10, which is really just a quantitative neurological exam. 0 perfect, 10 you're dead. So the higher you are, the worse the neurological exam. But we're also looking at the MS disease duration over time. And this is a very important point. If we see very early on rapidly accumulating disability, that is a warning sign. We should be very worried about that patient. In that case, the efficacy of the disease-modifying therapy that they're placed on becomes critically important. So please remember, it's the pace of disability early on in this critical window of opportunity time that is so key. Now, our current landscape of DMTs, if you count all the generics, we have more than 25 DMTs covering 10 mechanisms of action. You can't possibly talk about them all, but you can put them into 3 groupings. There are the injectables, glatiramer acetate, and the interferon betas that go back really to the 1990s. Immunomodulatory, not immunosuppressive. We know exactly what they do, what their side effect profile is, quite safe. A myriad of orals from cladribine, an induction durable immune reconstitution long-acting agent, to the fumarates, dimethyl fumarate, generics, diroximel fumarate, monomethyl fumarate, to the S1P receptor modulators. The first in class, fingolimod, hits S1P receptors 1, 3, 4, and 5. 3 second generation S1P receptors approved, ozanimod and siponimod that hit S1P receptors 1 and 5, and ponesimod that hits S1P receptor 1, and teriflunomide. And finally, the monoclonals. These are the high efficacy agents, but typically are considered to have more risk. Alemtuzumab, natalizumab, and the 2 anti-CD20s, ocrelizumab and ofatumumab. This is a phase 3 trial of cladribine, oral cladribine, Clarity, where it looked at 2 different doses. The approved dose wound up being the 3.5 milligram per kilogram against placebo. This is looking at 3 months confirmed disability progression, and you can see both arms work very, very well. This is an agent that you take for 5 days in month 1, 5 days in month 2. You don't treat again for a year, and then you take it in 5 days in month 1 and 5 days in month 2. You don't take it again for the rest of year 2 or year 3 or year 4. It's a long-lasting agent that really lyses lymphocytes, B and T cells, and has really an induction property. So this was highly successful in this phase 3 trial against placebo. This is the phase 3 trial of one of the second generation S1P receptor modulators. It was Expand and Siponimod. What was special about this was this phase 3 trial entered progressing secondary progressive MS. So their major phase 3 trial was in slowly progressing secondary progressive MS patients against placebo, and they met the primary outcome. 3 months confirmed disability progression was significantly lessened with Siponimod versus placebo. Now, this was actually critiqued at the time in an editorial, but just think about it. How easy is it to get a benefit on neurodegeneration when you have patients that are plunk in the middle of clinical neurodegeneration? Not so easy. You're not going to get a slam dunk amazing effect. This met statistical significance, and we can see on the right 6-month confirmed disability improvement. This is really ENDORSE, which is emphasizing the importance of open label extension and continuing to look at patients. This actually took the 2 phase 3 relapsing trials of dimethyl fumarate, DEFINE and CONFIRM, and they offered patients to continue in the open label study. On the left, we see the patients that were randomized to dimethyl fumarate from the very beginning of the trial, the first 2 years. And we see that in the open label extension, it continued to control clinical relapses quite well. On the right, in gray, those patients were on placebo the first 2 years. We see that their relapse rate, their annualized relapse rate is much higher. But then when they were switched over in the open label to dimethyl fumarate, we see a nice fall, and this has been maintained 9 years. This study actually went out as long as 13 years. So open label studies are very important. Now, there is one of the fumarates, diroximel fumarate, that was studied in 2 phase 3 trials, EVOLVE-MS1 and EVOLVE-MS2. This is EVOLVE-MS1, which was an open label single arm study to really document the safety as well as look at the efficacy of diroximel fumarate taken twice a day as an alternative to dimethyl fumarate. They divided their overall population, which was close to 700, and they looked in particular at a newly diagnosed group that was about 82. Now you can see that on treatment, the annualized relapse rate, the adjusted rate, clearly went down. Now remember, these people had data coming in, had been observed for a year. The annualized relapse rate went down. So you saw efficacy here. This was the second phase 3 trial, EVOLVE-MS2. This was a randomized prospective, only 5 weeks, but relapsing patients were randomized to either dimethyl fumarate or diroximel fumarate. The focus was on 2 patient-reported outcomes involving GI symptomatology. GI symptoms were significantly less in the group randomized to diroximel fumarate over dimethyl fumarate. It really confirmed that diroximel fumarate had the active ingredient, but really was packaged to cause less GI upset. And of course, that is a very valuable thing. This is another second generation S1P receptor. This is ozanimod. This had 2 phase 3 trials, Sunbeam lasting 12 months, Radiance lasting 24 months in relapsing MS, where patients were randomized to 2 different doses of ozanimod. The higher dose, the 1 milligram, wound up being approved, or IM interferon beta 1A 30 micrograms weekly. We're looking at the primary endpoint, the annualized relapse rate. We see the best data is really with the dose that wound up being approved, 1 milligram. There was also significant improvements in MRI parameters in favor of ozanimod over the IM weekly interferon beta. They did not, however, see a difference in either 3 or 6 month confirmed disability worsening. Of course, these were relapsing patients. This is the famous phase 3 trial in primary progressive MS that wound up getting the first and only DMT approved for primary progressive MS. This is Oratorio. This is with ocrelizumab versus placebo, primary progressive MS, randomized to either the humanized anti-CD20, 600 milligrams IV every 6 months, or placebo. And 12 weeks confirmed disability progression was the primary outcome, and that was met. You can actually see the separation is occurring by 24 weeks, by 6 months. This wound up being approved in March 2017, not just for relapsing forms of MS, but primary progressive MS. Now we turn to the human anti-CD20 that was approved in August of 2020. This is ofatumumab. Ofatumumab was going to compete directly with ocrelizumab, the humanized anti-CD20. They decided they were going to make the delivery system subcutaneous. They decided they were going to use a lower dose of anti-CD20, but more frequent dose, 20 milligrams every 4 weeks. These are the two big phase 3 trials in relapsing MS, Asclepios 1 and 2, that were recently published in the New England Journal. And here, the active comparator was oral teriflunomide. And you can see the annualized relapse rate, which was the primary outcome, statistically significant in favor of ofatumumab over teriflunomide, confirmed disability worsening significantly in favor of ofatumumab, contrast lesions, new enlarging T2 lesions, significantly better suppressed with ofatumumab, serum neurofilament protein, significantly lowered with ofatumumab, but confirmed disability impression, not significantly different, and brain volume loss, not significantly different. Very interesting for teriflunomide versus ofatumumab. This is the new kid on the block that was approved not very long ago. This is a second generation S1P receptor ponesimod. And in their phase 3 trial, it was the first phase 3 trial with 2 orals. Ponesimod, 20 milligrams PO daily, went against teriflunomide, 14 milligrams PO daily. The annualized relapse rate was the primary outcome, and that was significant in favor of ponesimod. Combined unique active lesions also favored ponesimod. Confirmed disability accumulation was not statistically significant between the two, but there was significance in favor of less brain volume loss with ponesimod and achieving NIDA-3. So I'll turn it back to Aaron.
Dr. Coyle, thank you for going through that so eloquently. It's so exciting to be involved in this field with all of the therapeutics that are coming to market. And it's obvious that as we try to pick the right drug for Natasha, we have a lot of things to consider. I'd like to shift our attention now to emerging therapeutic options. And today we're going to be reviewing several. There is an anti-CD20 ublituximab. There is a receptor tyrosine kinase, masitinib, which we'll be talking about, as well as 3 Bertin tyrosine kinase inhibitors that you see listed there. So let's jump in and talk about these emerging therapies. Now, this is arguably one of the most exciting. This drug is the first drug in the armamentarium being studied to affect the innate immune response. Most of the therapies that we've been talking about, almost all the therapies we've been talking about, really work on the adaptive immune response. And here we see that we can actually affect mast cells. This is pretty exciting stuff because this tyrosine kinase inhibitor interferes with mast cell survival, migration, cytokine production, degranulation. It's doing a bunch of different things mechanistically, which will have a bearing on permeability of blood-brain barrier and also in T-cell activation. Very, very exciting to consider this drug. And when you look at the recently revealed data, it's even more exciting. Now, what you see here is a clinical trial, which was looking at people with MS who had progressive disease, either primary progressive MS or non-active SPMS, meaning they weren't having attacks or new spots. And this was a placebo-controlled investigation. There was different doses, but you can see something very interesting that the higher dose was not found to be statistically significantly better than placebo, whereas the lower dose, the 4.5 milligram per kilogram, performed remarkably well. So as we look at the the outcome measures, the primary outcome measure was actually the change across time in the EDSS. And this hit the mark. That's a pretty big deal. As Dr. Coyle pointed out beforehand, demonstrating change in progression is not an easy thing to do. Now, if instead you look at the hazard ratios for risk of EDSS progression or the risk to starting to have progression, again, this mast cell receptor inhibitor is doing something rather remarkable, and it's improving progression. It's slowing it down. It's preventing as quick as it's going to come on. And it didn't hit the mark with a more classic 12-week confirmed disability worsening. Now, in the subgroup analysis, when they broke out just the PPMS patients and just the non-active SPMS patients, that data still held true. And I'm very excited about this agent. I'm excited to see where it ends up. I'm delighted at the idea of having something to work on the innate immune system with efficacy like this. It's also relevant to point out that this is a pill, so it's not an infusion or an injection. Now we turn our attention to a new class of medicine, which is being very aggressively studied. Multiple different manufacturers have brought various versions of BTK inhibitors to trial. There's a lot of ongoing investigations actually right now. Now, BTK inhibition is an interesting mechanism. Again, we're doing something a bit different than what we've done in the past. Here you see on the screen one of the sites of action of BTK inhibitor, and that's really to interfere with B cell communication. As Dr. Coyle pointed out, we have drugs presently that are anti-CD20s that deplete B cells by murdering them. This is doing something a bit more subtle. It's kind of blocking them so you can't hear them, but it's not killing the cells. The other thing that bears mentioning is that some of these BTK inhibitors seem to have an effect on the microglia in the brain. Microglia are another innate immune cell that we've not been able to get a hold of in the past. And so there's a tremendous amount of promise, and there's going to be a lot of data coming out as we understand these and as the trials progress. With that background, talking about the currently FDA-approved therapies, the ones that recently just got approved, and some hopeful therapies, I want to go back to our case and discuss individualizing treatment specifically for Natasha. And so we're going back to this initial visit, and I completely agree with Dr. Coyle. It is a best practice after a diagnosis to have a separate discussion for disease modification. There's simply too much to talk about, and it's inappropriate, in my opinion, to rush someone past this decision. This must be a shared group decision, because this is something you're asking the human being to do for a very long time, and you're not going to be there to supervise. They have to buy in, they have to agree, they have to be on the same page as you. And so carving out dedicated time for this discussion, I think, is absolutely imperative. Questions and concerns that might come up are oftentimes not what the clinician's thinking about. Natasha may bring up concerns about logistics. During a COVID era, it's a very big deal to have to leave your house. How much time might she have to spend in an infusion center if she were to pick an infused therapy? What risks would that curtail? We also want to think about the cost point of the medicines, and if there's a hidden costs and so on and so forth. We have to think about the monitoring, because it's not just about taking the medicine, it's about the safety monitoring involved. And Natasha may find that a pill is very easy to take, but that getting a bunch of lab draws is not something that she really wants to do. So we have to kind of think through that. There is a natural hesitancy towards brand new therapies because they haven't been tested yet, or they're not out in the market. And it's understandable that someone may shy away from something brand new. I also think that it's relevant during this initial conversation to talk about the long-term disease, because this is a disease that Natasha will die with, not from, but it risks making her disabled if we do this wrong. And so talking about the disease impact over time, I think, is important. Talking about the goals, the long-term goals of functioning, and helping make sure that she can provide for her family and be there to enjoy her family and to provide. These are all important discussions to have. I'll sometimes ask the patient to channel their self 20 years from now to the table and ask themselves 20 years later what those person's goals are, to try to help them think into the future. Dr. Coyle, could you please comment on your approach to having that future conversation with patients, please?
Really, I do indicate that we don't have the ability to cure MS at the current time.
Yep.
It is very important that we control it so that the person can live a normal life and achieve all of their hopes and dreams vocational, marriage, children, whatever. An important aspect, I think, that we're increasingly realizing is how important appropriate lifestyle choices and
Yes.
wellness program are to boost CNS reserve and allow the individual with MS to age better. It's also an increasing observation of how critically important it is to consider comorbidities in MS, comorbidities like vascular issues or even depression that may assault the central nervous system. So I'm now finding that's a key cornerstone that I discuss very early on, right up front, how important it is not to smoke, how important it is to regularly exercise, particularly aerobic, how important it is to be optimum body weight, that this can really help the person achieve their lifelong goals and treat MS as well as possible. If it's ignored, you can have the best DMT. It's not going to be as good as if you're combining it with all of these other factors.
You're spot on. I have a saying that I want my patients to be 4 for 4 in their fight against MS. And it's a simple way of reminding them that I want them to not smoke things. I want them to eat clean and supplement vitamin D. I want them to exercise as part of their lifestyle. And I want them to take a DMT and make sure it's working. And it really speaks to this whole concept of brain health and bringing to bear all the different avenues. Now, all that stated, we still have to pick a drug for Natasha. And it's relevant to kind of contemplate what are the really key things that we're going to be thinking about as we try to make this important decision with her. Now, one of them is, do we feel we need a high efficacy medicine, and is that appropriate? We also desperately need to include the human being in their own decision because we're not the ones taking the drugs. And so listening to Natasha's goals, listening to her preferences, and understanding where she's coming from is paramount to a successful long-term relationship. Here we see some more granularity surrounding a patient-centered treatment decision. In the middle of the screen, we have the goal of the right drug for the right patient at the right time. And as you go clockwise, we can see various elements that play into that. What is the relative efficacy of the drug that we're discussing, and is it appropriate for our understanding of the aggressiveness of her disease? How about the safety and tolerability? Are there going to be hangups or issues or barriers there? What's the dosing schedule like? How do we evaluate initially, and how do we monitor long-term? And of course, in the real world, we also have to consider cost. All of these factors come to bear. Now, considering relative efficacy, this is arguably a contentious slide. We have tried to share with you general concepts of efficacy, although it's very important to state that there are no head-to-head trials across all these drugs. So some of the drugs have head-to-head comparisons, many do not. And this is a tremendous amount of opinion. So if I read through it with you, I do think that it has some validity. We would place the interferons and glutaramine acetate and then teriflunomide in the lower area of efficacy. That's not to say they're not efficacious drugs, but maybe compared to some of the others, they have not fared as well. We would put the fumarates next, and probably a little above the fumarates, the various S1P1 receptors, Gilenya et al., that we had been discussing earlier. And then cladribine, this is the oral microinduction therapy. And at the top, or the top shelf, is where we look at the monoclonal antibodies, alemtuzumab, natalizumab, and the various anti-CD20s. Dr. Coyle, would you like to weigh in on this slide?
I would basically agree with it. It's interesting. I was in a meeting where a fairly prominent person pointed out that he felt that the fumarates were equivalent to the S1P receptor modulators and should not be put on a lower efficacy. So
Sure.
Everyone has, when you don't do randomized prospective head-to-head, you don't have the true, golden evidence-based data. So I think we could argue, but I think this is pretty reasonable.
I agree. I mean, I think some people might put teriflunomide down a notch, or they might put cladribine up a notch, but I agree with you that generally speaking, this is a reasonable way to think about relative efficacy. Let's turn our attention to the impact of early intensive therapy on a 5-year EDSS course. Now, what we're looking at here is an association between first-line DMT strategy and then what we see 5 years later when we measure disability. And as we look through this data, We have the high efficacy early application, and then we have the first line application. We can kind of look through the differences. And what we see is, in my opinion, compelling. We see that the early application of a highly effective therapy tends to fare better long-term when you look out 5 years. The following investigation explored the earliest application of highly effective therapies as compared to starting highly effective therapies at a delay. And it's looking at the accumulation of neurological disability over a period of 8 years. And what you see is a stark difference. Amongst the patients who had the earliest application of highly effective therapies, the trajectory of their disease seemed to have been shifted. And when you look at the hazard ratio of progression, that hazard ratio of 0.3 is pretty compelling. This data would start to lead credence to the idea that applying highly effective therapies earlier might result in a better long-term outcome. In fact, this is a lesson that we've learned in the past. Here we see the PRISMS 4 trial. This is going way back in the 90s. And when we looked at Rebif. Now, the original trial for interferon beta 1a Rebif was called PRISMS 2. It was a 2-year trial. And it was a placebo versus being on Rebif. And after 2 years, all the placebo patients were put onto active drug. And so just like in the last investigation, you had an early and a late start. And what you can see is very similar, that the earlier these people started on interferon, the better they did long-term. One might submit that we're now learning that the earlier application of highly effective therapies might also improve outcomes, but that still remains to be fully tested. Here we turn our attention to the ocrelizumab trial suite and looking at the OPERA trials, where we compared ocrelizumab against interferon beta 1a Rebif. And what you see on the left-hand side is confirmed 3-month disability, and on the right-hand side is 6-month confirmed disability. Clinically, I tend to prefer looking at 6-month, but here we have the data for both. And what we see when you're looking at the risk of confirmed progression is that the patients that were randomly assigned to take ocrelizumab accrued less neurological disability over time as compared to the interferon. And that was true both with a 3-month and with a 6-month investigation.
So now let's talk about safety and tolerability. And these are important topics.
Very.
You could have the most wonderful disease-modifying therapy, most effective, shut down disease activity. If it's not safe or it's not tolerable, it's useless. It's a bad drug. You're not going to use it. So this is a very important concept. And I think for the most part, all of our DMTs are available and being used because they are relatively safe and tolerable. When we look at the injectable therapies, their basic issues are the fact that they're injections with various injection site reactions that are typically well tolerated. And we've learned a lot of tricks using pens, et cetera, to try to get away from the needle fear. The interferon betas also have a flu-like reaction. When the very first interferon beta was used, people had no concept of dose escalating and pre-medicating and maybe using an early evening dose that would peak during sleep. We can actually mitigate most of the flu-like reactions. For the orals, there are a variety of safety and tolerability issues. Cladribine, which causes a profound lymphopenia for a while, puts people at increased risk for infections such as upper respiratory tract infections. You can't use it in a patient that has cancer. That was a fear that it might cause that. It was due to be the first approved disease-modifying therapy orally, but they couldn't answer the cancer issue and thus pushed back, but ultimately got approved because it looked like it didn't cause much cancer. The fumarates, the classic are flushing that we still don't have a great treatment for. You can use aspirin. And the GI-related issues that really fueled the development of diroximel fumarate and monomethyl fumarate. Then we have the S1P receptor modulators, the parent fingolimod, and the 3 second generations, ozanimod, siponimod, and ponesimod that's not listed here, it's too new. These all have very similar features. One little wrinkle with the S1P receptors, they can raise the blood pressure a little bit, typically very, very modest, but something to be aware of. And things like headache And in subsets, one can see infections, particularly with fingolimod. And then we have teriflunomide, 14 milligrams oral daily. We're the only country in the world that also has 7 milligrams. You prefer not to use that because it's not as efficacious, but sometimes with tolerability, that may be the only thing that a patient can take. We know about hair thinning. We know about the black box warning. That comes from leflunomide. Leflunomide is an oral rheumatoid arthritis drug that's been on the market since 1998. And in the RA populations on their multiple drugs, there were some cases of liver failure and liver toxicity, and in animal models, teratogenicity. So leflunomide had the black box warning. It got put on teriflunomide. I will tell you, teriflunomide does not have a lot of liver enzyme issues. It's very interesting what you get stuck with. And then we can turn to the safety and tolerability of the monoclonals. Alemtuzumab, anti-CD52, this can give nasty infusion reactions. You really need to pre-medicate with steroids. And then you need to take oral antiviral agents for the first couple of months after you get the dosing. Alemtuzumab is a very interesting induction, durable immune reconstitution. 5 days in year 1, 3 days in year 2, then you don't treat again unless there's breakthrough activity, maybe 50% go a decade or longer. Natalizumab, really well tolerated. The real issue is the progressive multifocal leukoencephalopathy, or PML. This is the one MS-DMT that really has high risk of that. Over 800 cases have been reported. And then the anti-CD20s, ocrelizumab, ofatumumab, statistically, first dose side effect from the infusion. That's why they split it up. You give 50% 2 weeks apart. You're routinely pre-medicated, but actually it's tolerated very well. And then in theory, a concern about ultimately low immunoglobulins, in particular IgG, that might make individuals vulnerable to infections. We also need to think about monitoring. We need to discuss that with our patient and shared decision-making and educate them. We want to make sure that the MS patient is going to follow through on monitoring. Gluteramine acetate is the only DMT that needs no monitoring whatsoever. That's a big plus for it. Interferon beta routinely, CBC with diff, liver, enzymes, thyroid functions. Teriflunomide, the label requests that you send an ALT monthly for the first 6 months. Most people will do that. Teriflunomide can also have a blood pressure issue along with the S1P receptor modulators, so you would look at that. So you want to think about the monitoring schedule that you have for the various disease-modifying therapies. And then the monoclonals, the monitoring for them. With alemtuzumab, annual skin exams and human papilloma virus screening. There's mandated monthly bloods and urinalyses for 4 years, 48 months after the very last dose. That's followed very closely. With natalizumab, often people will do every 3 months JC virus antibody and index testing and more frequent MRI scans as well, and may go to extended dosing to 6 to 8 weeks to lower the risk. With the anti-CD20s, you're mandated by the label to check for hepatitis B. We also check for hepatitis C and TB and IgG to varicella zoster, and we do quantitative immunoglobulins, and they should be monitored. They should be monitored. The real concern is potential IgG with vulnerability to infections after a number of years of taking an anti-CD20. This is a very important slide. This is from the NARCRIMS registry of MS individuals. It's pointing towards the fact that we realize there are differences based on race and ethnicity in MS disability and use of healthcare with regard to disease-modifying therapy use. This is pretty shocking, but it drives it home, and everybody needs to be aware of it. If you look in this registry at Black and African American patients with MS versus white Caucasian patients, those that had an EDSS 4 or higher, 20% versus 9.7%. Greater disability in African Americans than Caucasians with MS. Look at the right-hand slide. DMT use, 62% in non-Hispanics, plummets to 43% in Hispanic patients, and only 26% in Black and African American Hispanic patients. This is an embarrassment. It's a national embarrassment. We should not have any differences in access or use of treatments based on race or ethnicity.
Amen.
So returning to Natasha and her second follow-up visit, she has decided to start treatment with ocrelizumab. So, Aaron, how would you think about this? How would you talk to her with regard to expectations of how long it would take the DMT to be effective, and what would happen if she had early breakthrough activity, and when you're going to do the next MRI scan? How would you counsel the patient?
This is a very important point. Setting up realistic expectations is such an important thing to do early on so that the patient understands the guardrails and understands what can and may not happen. So as it relates to Natasha and starting ocrelizumab, I would want her to understand that clinically this drug works pretty quickly, and that radiographically it works pretty quickly, maybe slightly slower on some of the metrics radiographically. And it's going to be very important in my mind that we re-baseline the MRI. And so I think this has become generally standard practice amongst MS neurologists, where we start a DMT and then a couple months later, we get a re-baseline MRI. And we don't want to wait a year to check that scan because we won't know if spots had occurred right before starting ocrelizumab or in the first month, maybe before it had fully kicked in. And so I typically like to get a re-baseline MRI at 6 months. If I see new lesions on that rebaseline, I'll repeat it 6 months later. If I don't, then I'll start my annual monitoring. And so I like to set all that up front so that the patient knows what to expect. Do you do things a bit differently at Stony Brook?
No, I think that that's exactly what we would do. I generally counsel patients it's going to take maybe 2 to 2.5 months for a DMT to be fully operational. So if somebody's very active, you might see disease activity in that short time period. Typically, the surveillance MRI scan, people have done 3 to 6 months. That's your new baseline, absolutely, going forward. But if you saw something on it, I totally agree. I would do the next surveillance MRI scan somewhat sooner. Yes, absolutely. So, for Natasha, evaluating treatment response and disease monitoring, how do we do it and what would be employed? Ideally, we'd like absolutely no disease activity. I like the American Academy of Neurology 2018 practice guidelines that say when you're a year on treatment, if you have one or more clinical attacks, or you have developed some disability on the neurological exam, or you have 2 or more MRI lesions that have developed over that year, that should trigger a switch discussion. And I think that that's a very good guideline. Would one MRI lesion make me switch? Probably not, but I would have a dialogue and it would probably change when I did the next surveillance MRI scan. You really would like to see this. This is the window of opportunity. This is early treatment. This is when you really need to follow the patient and make sure that you're not seeing breakthrough activity and act on it accordingly with a number of different measures. And I think people have talked about the EDSS, which is really a quantitative neurological exam, the MS functional composite, 25-foot time walk, 9-hole peg test, symbol digit modality test. You can do that in a few minutes. You don't need a physician to do that. The MRI data, contrast, new enlarging T2 lesions, a wave of the future, brain volume, spinal imaging, wave of the future, slowly expanding lesions, often with a phase rim. These have been correlated with disability and risk of progression and predicting secondary progressive disease. And again, a wave of the future, not ready yet, but serum neurofilament light protein and perhaps glial fibrillary acidic protein, GFAP, and astrocyte marker. Aaron, do you want to make a comment on any of these monitoring?
I think that all of us are classically trained neurologists, and we grew up doing neuro exams, and we all are married to the EDSS in many ways. It's required by the FDA for clinical trials and so on and so forth. But I really think in the day-to-day clinical practice, at least in my practice, I find using patient-reported outcome measures, and we do the MSFC with every patient, every visit. I really find that clinical information, in some cases, particularly early on in the disease, to be more enriching as I try to understand the patient. The only other comment that I'll make is I am super excited at the prospect of having neurofilament light chain in the serum be commercially available. It's my hope that we're only a few years off, and I think that has the potential to be quite a game changer. It's an exciting time.
You know, they just had a very large study of neurofilament light protein in thousands of MS individuals. It's affected by diabetes. It's affected by smoking. It's affected by sex. All of these things are going to need to be accounted for when we get down to the one-on-one individual patient.
And age.
Yeah.
So it's not prime time, which is, you know, as you've presented, but the potential to have a biomarker like that would really be something to.
Absolutely.
Yeah.
Absolutely. And then I just make the mention, we have some very nice patient-reported outcomes. We use the MS fatigue impact scale. It's a 1-page, 21 questions. The patient fills it out as they're waiting to come in, and we add that to their record. But you want to know what a PRO is? Asking the patient, how are you doing?
Yeah.
How are you doing? Asking the patient how they're doing. That's self-report and gives you, you know, a very valuable handle. Okay. Yep. Now, this is a very interesting slide. It's from a recent article that did an analysis of the OPERA 1 and 2 phase 3 relapsing trials that established ocrelizumab, the humanized anti-CD20. So understand, these are all bona fide documented relapsing patients. What it looked at, and remember, they went head-to-head against sub-Q interferon beta-1a, 44 micrograms 3 times a week. Okay, what they looked at here was confirmed disability accumulation. So getting disabled, worsening, and it was confirmed over time. And they looked at, was this related to relapse associated worsening, or so-called RAW, or progression independent of relapse activity, the so-called PIRA. It turned out in these relapsing trials, the ones that worsened on the EDSS were doing it with progression, meaning the neurodegenerative stage. So these were relapsing patients that were entering secondary progressive disease, gradual worsening, reflecting neurodegeneration. We need to be on the lookout for this, and this is really addressing the great need to have neurodegenerative treatments. So this is sort of really amazing when you think about it.
It certainly is unsettling. And I think bringing these concepts to the clinic, even discussing the idea that you can not fully recover from an attack and accrue disability, or you can accrue disability independent from attacks, even early on, is an important discussion to have with patients and families, I feel.
And it really pushes the wellness and control of comorbid factors and proper lifestyle choices. Optimizing MS management over the long term. So we come back to Natasha. It's now 2 years later. She reports she's not had any acute attacks, but she's continuing to experience some ongoing symptoms: fatigue, sleep disturbance, bladder incontinence. In fact, when we speak to her with regard to lifestyle and behavior changes, she's taken a new position at work because it requires less travel and time commitment. How is she doing? Is she passing the litmus test here? She has 3 significant symptom management areas, and she's actually changed her job. How does she feel about that? Is she sad? Is she disappointed? What are we going to do about this? There are a lot of concerns here that we could talk about. Aaron, would you like to weigh in on this?
Yes, please. You know, it's a fool's errand to look at a human with MS and say, no attacks, no new spots, then they're doing great. That's to miss the vast majority of what's going on in their lives. And I think this slide kind of brings that home. This is a woman who is failing the litmus test of life. She's not living her best life despite having MS. And I think it's incumbent on her team, on the clinicians that are helping her to improve her fatigue, her sleep, her bladder, to, if she wants to be in a particular environment at work, to help facilitate through rehabilitation, et cetera, the opportunity to do that. I think this brings up a really important case in that we picked a lovely disease-modifying therapy, and 2 years later, she's not had attacks. Good job, team. But we're not remotely done. I think in order to feel proud as an MS neurologist, we have to do 2 things with every patient. We have to slow their disease down, and we have to improve their quality of life. And that's what I would like to see us do with Natasha moving forward.
Absolutely. I totally agree. You take in the whole of the patient, and it's important that she is living an excellent life and achieving her dreams. And if that's not happening, uh, we need to step in through better symptom management discussions. We want to think about her mental health, because that's going to help her neurologic health and her physical health. So finally, let me consider barriers to adherence among patients with MS. This is an important concept. In shared decision-making, we want to make sure that the patient is going to take the medication, because if it's not being infused and you're very clearly documenting it, you're dependent on somebody injecting a needle at home or taking oral medications at home, it's really key that the patient intellectually buys in and will do it. So we consciously think about adherence compliance in the shared decision-making process in selecting or changing disease-modifying therapies. So as the person indicated needle phobia, or that may not be a good choice for that individual. Are they reporting adverse events or side effects? That's a warning sign. Have a further discussion. Can that be fixed? Do they have issues that may interfere with adherence, like cognitively, they're not proper, they're forgetful, or they're depressed, and that may really involve their motivation in being fully adherent. Do they have unrealistic expectations? I thought this was going to make me better. I thought this was going to take away all my MS symptoms, and it didn't do it, so it's a failure. That was shared decision-making failure, because we did not educate the patient and make clear. And is there such poor communication, and this does happen, we all know it, that the patient stops their DMT and doesn't inform their doctor, okay? You really want open lines of communication so this does not happen. This is very important from the very beginning.
This is such a good reminder of the work that we need to do as we shepherd patients through this process.
So Aaron, let me turn this next section back to you.
Thank you, Dr. Coyle. Here we're going to wrap up with a rather timely and contemporary discussion. Here we are discussing helping people live their best life despite having MS. We have to also discuss the fact that we're trying to do this presently during a global viral pandemic. And so let's spend a bit of time talking about how we're trying to navigate management of MS during the COVID-19 era. So thinking about Natasha again, we're doing a telehealth visit, and in full transparency, over half my clinic these days is still telehealth. And she fortunately reports no new attacks, but has very appropriate concerns about COVID-19. These are questions which I'm asked almost every clinic visit these days. They're very, very appropriate questions, and we have to be prepared for this conversation. Is she at greater risk of the COVID-19 infection because she has MS? Is she at greater risk because she's on a particular DMT, ocrelizumab? Should she stop her ocrelizumab, or should she change the dosing schedule? Should she be vaccinated? If she's vaccinated, will the MS impact the response, or will the vaccine trigger an attack? And if she's vaccinated, will it work given that she's on this anti-CD20 molecule? What if she were to develop symptoms of COVID-19? What would we do? And if she has an attack, would we be able to give her steroids, given that we have data that steroids increases the risk of a more severe COVID? This is very real world, and this is absolutely germane to day-to-day clinic nowadays. There are several critical questions that I think we want to bring to the table when we're managing people impacted by MS during the pandemic. Number one, are patients with MS at greater risk of COVID-19 infection? And my answer is no. You're not immunosuppressed with MS by itself. In fact, you have an overly active immune response. And unless you are severely disabled with decreased lung capacity and decreased ability to move, I'm not sure that I would think you'd be at increased risk. Number two, does MS put patients at greater risk for complicated COVID disease? Again, taking the patient, not the drug they're on, but I think that we're going to be looking in a couple slides at other comorbid risk factors, which probably play a larger role than just the fact that they may have MS. Number three, should patients continue to adhere to their DMTs as usual? This is a very, very timely discussion. Fortunately, several of the MS organizations internationally have helped weigh in. And by and large, we're asking patients to keep on keeping on. They still have MS, and when the global viral pandemic's over, they're still going to have MS. But as an individual, each case, we have to consider the totality of the situation. Number 4, are certain DMTs associated with a greater COVID infection risk compared to others? And I'm going to share some data on that in just a second. Number 5, should patients with MS be vaccinated against COVID-19? And my answer is a resounding yes, yes, yes. We'll talk about that in a second. Number 6, how should COVID-19 infection be managed in patients with multiple sclerosis? This is a very, very big concern. Patients want to know what to expect, when they should present to the hospital, if they need to go to the hospital. We talk about that a lot. And lastly, number 7, how do we optimize MS care under the restrictions necessary by the pandemic? In other words, when we talked to Natasha, it wasn't in office, it was on telemedicine. And how's that changing how we do things? Here we see results from the COVID MS registry. This was a fantastic effort from many, many MS neurologists and collecting information about their patients with MS who then developed COVID-19. And what we're seeing here is really a readout on how they fared. Now, fortunately, the vast majority of the patients, 64% almost, fully recovered. And at the time of this investigation, another 26% were recovering. We see that the rate of death is very, very low. And it's my observation that this is in keeping largely with what we would expect in the general population. I don't know, Dr. Coyle, if you would care to comment?
I would say that this is true, that I really don't think that this is out of line with the early. Now, we've gotten much better, and I think the monoclonal antibodies have made a big difference in mortality.
Yep, I agree. This investigation I found to be very, very educational. And what we're looking at here are people impacted with MS, and we're asking the question, are they at risk of having a more severe COVID or not? And are there factors, demographic factors and clinical factors, even MS medicines that might alter that risk? And so what you see with the red highlights are really where we kind of want to bring your attention. And just to help you understand, if the box is on the left side, there's a lower risk of a severe outcome. And if the box is on the right side, there's a higher risk of a severe outcome. And so this is actually very much in keeping with what we would expect in the general population. We know that the older you are by decade, the higher the risk. So a 60-something is going to be at higher risk than, say, a 50-something. Being a man is a worse outcome than being a woman. And having comorbid risk factors, heart issues, lung issues, diabetes, these are very, very relevant. We see smoking kind of crosses the line. Obesity is a factor. Now, as we go lower on this list, we start to get into some concerning MS areas. And what you see is, if you have a higher EDSS, then you have a higher risk. And the thought is, with higher EDSS, there's more accumulated neurological disability, placing the person at higher risk of a more severe infection. And then we look at some of the MS medicines and where they shake out. And in this investigation, it didn't appear that the use of these medicines would increase the risk. Now, that's not the only investigation, and there's a tremendous amount of ongoing work. Here we have some recommendations recently put out by the National MS Society. And it's taking a more granular look at the individual disease-modifying therapies and asking, do we think that there might be an increased risk? Now, this is works in progress, and some of these comments are a bit contentious. The data is coming in, but I think, and I'd be curious about Dr. Coyle's impressions, that this is probably generally true. Now, we don't consider the injectable agents, the interferons, glutaramine acetate, to increase the risk of a more severe COVID. And same thing with teriflunomide. So in all things considered, those are sort of in the safest of categories as it relates to COVID severity. We then look at the fumarates, S1P1 receptors, and natalizumab. And here we also are largely happy, not thinking that there's a significant increased risk. I might make a caveat that if you are on a fumarate and have the side effect of lymphopenia, that might change that discussion slightly. We then turn our attention to the anti-CD20s. And I would submit that this is the most contentious discussion. There has been some data suggesting that patients on anti-CD20s, particularly rituximab, do have a worse risk of COVID. And there's been some other investigations that say maybe not. And I think that we need more data before we can settle that argument. Lastly, we turn our attention to the induction methods of action, so alemtuzumab and cladribine. And I think it's fair to say that we might need some more information. I also think it's fair to separate these two because even though they both use induction models, they do it very, very differently. And so what you can see here is a bit of works in progress in an attempt at trying to help guide clinicians as they think about using DMTs. Let's discuss recommendations for DMT use in COVID-19. Number one, continue your DMT. This is so very important, and we don't want to throw the baby out with the bathwater. As we just reviewed, many of the DMTs we view as very safe. Number two, if symptoms develop, or if you have a positive COVID test, you need to discuss with your clinician the therapies that you're on. I ask my patients, if you develop symptoms, if you test positive, call us, and that's a discussion. Number three, before starting a new DMT, identify the optimal choice based on the individual, right? So in the COVID era, you may choose to guide someone differently based on those risk factors. So if you had someone who was a bit older or maybe morbidly obese and they smoked, several risk factors for more severe COVID, that might alter your decision-making about what you put them on. Should patients with MS get the COVID mRNA vaccine? My short answer is yes. And in fact, that's probably a good answer for the majority of MS patients. Now, I certainly want my MS patients to be vaccinated, and I want their families to be vaccinated, and particularly those that are at higher risk. So our patients that have progressive disease states who are a bit older in age, those that have accrued neurological disability, those that have comorbid conditions like diabetes or high blood pressure, obesity, heart and lung disease, tobacco use, patients that are pregnant, and ethnic minorities. All of these risk factors place our patients at a higher risk of requiring hospitalization or more severe outcome, and I certainly want to push them to the front of the line. I mentioned the importance of immunizing the household because that person with progressive MS might not be going out of the house very often, but her husband is. And so if her husband's vaccinated and he comes in contact with someone with COVID and he acquires COVID, he'll kill it and he won't bring it home to her. Very important. Patients with MS, even after infection and recovery from COVID-19, I still recommend that they receive the vaccine. Dr. Coyle, is that also your recommendation, that even if you've had COVID, that you still get vaccinated?
Absolutely. That is the current recommendation. Typically, you're waiting about 4 months or so, but they are recommending vaccinations even to people that had COVID-19.
Yep. So now we ask the question, if you're on one of the disease-modifying therapies, might that alter your response to the vaccine? And it really depends on which therapy that you're on. Now, we're going to be talking about the DMTs, but it bears mentioning that this is not gospel and that this is still works in progress. We don't have all the data that we need, and we're really watching the evolution of scientific process in the now. That being stated, here are some initial impressions. If we're going to talk about the injectables, interferon beta or dimethyl fumarate, the impact on the immune response is not considered to be very significant. Similarly, if you're taking glutaramyl acetate or teriflutamide or the S1P1 receptors, or if you're taking natalizumab, we don't view this as having a major impact on your ability to mount a peripheral immune response. Cladribine, I think, has a lot to do with the timing. And there is a concern, hypothetical concern, that if you're lymphopenic, you don't have a lot of white blood cells, it might be harder to mount an immune response. And fortunately, with cladribine's microinduction, we can easily check the white count when it drops below normal and when it comes back up. And so at least here, it gives us a window of opportunity when we can weigh in to immunize at the ideal spot. Alemtuzumab, again, the timing is terribly important. If someone got alemtuzumab 4 years ago, I'm going to put them in that top category as not having any interference. Conversely, if you've had alemtuzumab in the last 6 months, I think that that risks a very significant impact on your ability to mount an immune response to the vaccine. And lastly, and arguably the most contentious discussion ongoing, is the impact of anti-CD20s on vaccine. Now, if you deplete your B cells with an anti-CD20, technically you're not messing with the plasma cells. But we do know that taking these medicines can have an impact based on the Veloce trial with ocrelizumab on the humoral section. So we give someone a COVID vaccine and they're going to mount a B cell and a T cell immunity. But the concern on the table is that if you're on a monoclonal that beats the B cells up, you might not mount a full humoral response. And so we would expect a partial benefit, but maybe not a full benefit, and much more to come as this data evolves and as we hear more updates. Patient education about COVID-19 mRNA vaccine is very, very important. I feel we are obligated to help people understand vaccinations in general and this novel mRNA vaccine in specific. And talking about the safety of the vaccines with patients is very, very important. People, particularly folks that are not medically savvy, are scared of the novel mechanism and sort of the newness and how quickly it was put together. And those of us that are familiar with the process understand that it was actually very appropriate and that it is safe, but it's important that we convey that to the families that we help take care of. There is a low likelihood that the mRNA vaccines will trigger an MS attack or worsening symptoms. Now, we've been managing patients that have been vaccinated quite extensively. And I will share that when someone gets a vaccine and they spike a fever for a couple of days, they can see a pseudo exacerbation. Fortunately, as with any other fever, when the temperature normalizes, those symptoms melt away. Side effects, again, we think about the pseudo exacerbation, helping patients with a realistic expectation. And it's important to talk about the benefit of the second vaccine, the booster. Again, this is an opportunity for a clinical neuroimmunologist to help a patient and family understand the why behind why, for example, with some of the mRNA vaccines, we do a 1-2 punch. The need for continuing measures can't be stressed enough. Just because you're vaccinated doesn't mean you can rip off your mask and kiss strangers. On the contrary, these measures are critically important to keep up. I've been vaccinated and I wear a mask in my clinic and I wear a mask outside my home. I wash my hands and I distance, and I need everyone else to do the same. Lastly, the delivery of vaccines nationally is quite a to-do, and each state is approaching it a little bit differently. It is a source of frustration for many of our patients that they don't qualify and that they're waiting to receive their vaccine. And in some respects, we can't choose the timing of the vaccine presently. And so even though we may feel there's ideal windows of opportunity to vaccinate, the take home, in my opinion, is if somebody offers you a vaccine, say yes. COVID-19 therapies for patients with MS. Now, there are some monoclonal antibodies that have been emergently approved that may help some patients. These are not FDA approved, but they are becoming available under certain circumstances. I'll share that some of our patients have received some of these monoclonals, and the idea is to get a hold of someone who's at risk of a severe COVID prior to getting really, really bad. Dr. Coyle, do you have any experience with some of these monoclonals to treat concerns for severe COVID?
I think I would really use them in anyone who came down with COVID. They can't be hospitalized, they can't be really sick, but that is in risk factors. You have nothing to lose, and I believe these monoclonals have been made free in the United States now to anybody because they haven't been used. They've been underutilized.
Yep, that's exactly right. And I think many of our patients are absolutely appropriate for this kind of therapy or intervention. I'll turn it back over to you.
So all good things come to an end, and I'm going to summarize our program. Early treatment approaches and the advent of more effective and better tolerated disease-modifying therapies have greatly increased the potential for improved symptom control and reduction of disease progression in MS. We have a wealth of disease-modifying therapies. That's wonderful. That's wonderful. MS is the poster child for success in the neurosciences. The expansion in treatment options has made it possible to provide patients with therapy that's highly tailored based on drug efficacy, safety, and personal preferences. While positioning of high efficacy therapies is an evolving discussion, recent and emerging data indicate that early use can have a significant beneficial impact on long-term disability in certain, in particular, high-risk patients. And a new but important part of MS management involves guiding patients as they navigate the current COVID-19 pandemic. As we've heard, we're learning on a regular basis. New information is coming in literally on a weekly basis, and we need to be nimble and keep up with that for our patients. In general, MS individuals should be provided education on their individual risk for becoming infected and counseled as appropriate to get vaccinated, continue using their DMTs as prescribed, and seek treatment in the event of infection. So I think we come to our Q&A period here. And it looks like the first question is, please comment further on the utility of NEDA as an actionable item in real world practice. So I can tell you my own sense, and then I'll turn it to Aaron. NEDA is an aspirational figure. The interesting data is when they've actually looked at it, it's very hard to maintain it. So for example, there's a single MRI lesion that forms. Does that mean you failed therapy and you need to switch? Probably it's too high a bar. Probably NEDA, minimal evidence of disease activity, is best. But certainly I think we are learning. We need better ways to monitor disease activity. Even with NEDA-3, you're not looking at microscopic damage at all. And we are searching out, and we spoke a little bit about biomarkers of disease activity that look very promising in the future.
And if I can just take a counterpoint position, I think that there are some aspects of NEDA which are attractive. So for example, if you think about NEDA-3, attacks, MRI changes, and disability on exam, this is something that every neurologist can do. So you don't need fancy special things in order to make that assessment. And even though it is an extremely high bar, it's aspirational, exactly as you said, it's very clear whether you hit it or not. The way that I like to use NEDA in my practice is if, God forbid, there's an attack or a new spot on MRI or new progression on exam, or if we're looking at brain volumes, we might talk about that, a NEDA-4 concept. If any of those are abnormal, that triggers a discussion. Now, it doesn't mean that we throw the drug out, but it certainly means that we talk about options and we come together again to make one of those group decisions.
So we're also being asked, is there any formal guidance to aid in decisions regarding optimal DMT sequences? You know, to me, the clear emerging therapeutic principles are early treatment, and we could debate what's early. My concept of early is within months of presentation. So I'm really talking about within 3 to 6 months of presentation. The Big MS database looked at 6-month epochs from presentation of MS to treatment over 5 years. The only thing that correlated with decreasing late disability was in the first 6 months. Yep. And it really echoes findings from rheumatoid arthritis. So I think early treatment is key. Treating at a young age is key. Really using shared decision-making to come up with the best choice. So for example, the debate about high efficacy. If I have a very active patient, if I have a poor prognostic profile patient, I'm really going to push high efficacy. But if I have a mild patient, but it really is important to them to be on a high efficacy agent, and I believe that agent is really relatively safe, then that's fine in that individual. Shared decision-making will trump. There's no reason not to go to a safe, high efficacy agent if that's what the patient wants.
I oftentimes will tell someone I want to put them on the most effective drug they're comfortable with. And that last part of that phrase is really important to your point.
And then our next question, how do you typically assess health-related quality of life in your patients with MS? Would you recommend the use of a validated instrument such as the MS QOL-54 or a less formal interview during follow-up adequate? What types of questions are most valuable for assessment? I must say we don't actually do a formal quality of life, but I think it's critically important to talk to patients. What is going on in their life? What's happening? Are they under stress? Everybody's in stress in this COVID pandemic, and you see people becoming frazzled and unraveling a little bit, and they don't want to talk about it because everybody is sharing the same response. Yet the isolation, the stressors. We need to open up so our patients feel comfortable discussing it, and then make sure we get them help. This is a very stressful time for everybody, honestly.
Absolutely. I completely agree. And, you know, in our practice, I'll check a patient-reported outcome measure for depression and for fatigue, similar to what you guys are doing, as a screening tool. But those do not replace good old-fashioned talking. I think if we can shut up and listen, there's a tremendous amount we can learn. And I definitely like what you said about trying to help the patient lead their best life and really engaging with them so they feel comfortable talking and sharing with you. That's so important.
Well, Aaron, I have really enjoyed this session with you, and I hope our audience has also found it very useful. Thank you so much.
Thank you, everyone. Thank you for your participation. Have a great rest of your day.